All right, so like I said, we're going to start with tumors and head trauma today. Obviously, the skull is a closed box. Cerebral spinal fluid, blood, and brain tissue. That's all that's in there. But because it's a closed box, there's only enough space for those three things to be at the levels they're supposed to be at, right? And the brain can compensate a little bit by kind of shifting from one to the other. It can't do it very much, and it can't do it very long. So that's when we talk about the Monroe-Kelly doctrine. And basically that's just what it says. The volume of any of the three increases, one of the other is going to have to decrease to compensate for it. And it's only applicable in a closed skull situation. So the physiological mechanisms that maintain our intracranial pressure are listed here, and we'll kind of talk about the different ways that it goes through, but it's the arterial pressure, venous pressure, intra-abdominal and interthoracic pressure, posture, temperature, and the carbon dioxide, basically, that maintain that intracranial pressure. So the way we measure it is with the gold standard is the ventriculostomy. Sometimes, when I was at Northside, I know that the students got really lucky because they would do it bedside in the neuro ICU there. Do they do it in the neuro ICU at Bayfront? Have any of you guys at Baycare seen them do it in the ICUs? I think they always do it bedside ICU. If the patient's in the ICU and it needs to be done, they can. So basically, they can measure in the ventricles, the subarachnoid space, the subdural space, the epidural space, the tissue itself. And what they do is they put a transducer in, and that actually measures the pressure. So what do you think? So we have this hole that this transducer is in, right, through our skull. What do you think the complication is? Infection. Infection, that's the big complication. There's just pictures there showing you of how they do it. So when we talk about an increase in cranial pressure, so increased ICP, decreases the cerebral perfusion pressure. So what's cerebral perfusion pressure?
The amount of pressure it takes to circulate blood to the brain.
The amount of pressure it takes to circulate the correct amount of blood into the brain, right? Sufficient blood into the brain. So because our brain requires a specific amount of glucose and oxygen, a constant supply. So when we talk about the CPP, the way that we get that is the MAP minus the ICP. How are you going to know your patient's ICP? If they have a ventriculostomy, there's really no other way that you're going to know their ICP, right? So basically, if your patient has intracranial pressure problems, they're going to have some sort of measuring device to be able to tell you what the ICP is. It's not just a number you can guess or kind of, look in the computer for. So the one thing you guys do need to be able to do is, if I give you some blood pressures, I need you to be able to come up with the CPP. So the MAP, there's a little cheat sheet over there on the side. So it's 1 times the systolic plus 2 times the diastolic, all divided by 3. That's how you're going to get your MAP. And then we will always give you the ICP. We will not give you the MAP, though. We want you to figure that out, right? And then we want you to tell us what this CPP is. There's, in your book, who's open to the brain chapter? Anybody?
1315.
1315, up in the corner on the right-hand side, there's a little box. And I don't remember the exact numbers that it uses, but there's an example up there. Here, Dallas, tell us what the example is.
So the blood pressure is 122/84. So then you figure the MAP off of that.
84?
84.
Divided by 3, right? So that's your MAP. So tell me what your MAP is. Plug that into your calculator. You guys all have your phones with you. I know you have calculators. remember we have to minus our ICP, so it gives you the ICP. Well, as I say, I think it's 12 in the book. So what's your CPP? 85. So if on a test we tell you that we want you to calculate the CPP and we just tell you their blood pressure and their ICP, you have to be able to know how to do that. So when we look at the CPP, we want it between basically 60. No, wait, that changed. Oh, yes. So the normal CPP is 60 to 100. Oh, I did change it on your slide. Good. And we don't want it higher than 150. So what's going to happen if the CPP is 60? Is you're going to start seeing signs of ischemia. So maybe some dizziness, blurry vision. Anything greater than 150, it's going to cause vasoconstriction, and the blood's not going to be able to get through. So when we talk about normal ICP, what is it? What does your book say? Anybody read? 5 to 15. Good. So your normal ICP is 5 to 15. So that's your intracranial pressure. So what do you think happens if it gets a little high? What's the first sign that you think is going to happen? Change in LOC, right? So you have a change in LOC and your patient, maybe you were talking to them an hour ago and you could hear them on the phone and now they're really quiet. You're going, they're not really responding. You're going to check the ICP. Anything greater than 15, you're going to call the doctor because that's outside of the normal range. They probably aren't going to treat until it's greater than 20, but your job as the nurse is to let them know if it goes higher than 15 because 15 is the low end of high. Okay? It's not, when it gets over 20, maybe, they'll wait a little while to see if it's going to come back down, but it can't stay greater than 20 for any longer, than just a little while. Otherwise, then the morbidity and mortality rates go up. Oh, who do we want higher? Think of a patient who maybe has something going on in the brain who we might want a higher CPP for. Stroke. So if we have a stroke patient, they might have an ischemic part in the brain, right? So sometimes you'll have all these high blood pressure readings. You'll be coming in, maybe you guys are coming onto the floor and you're getting your vitals and you're like, oh my God, this patient's blood pressure is 189 over 94. And you go to tell the nurse because that's obviously really high. And so the nurse says, oh, it's fine. And you're like, I don't know, that's really high. Hopefully the nurse explains to you that maybe the patient is a stroke patient and we need it higher. Because if we don't get that systolic up a little bit, then our MAP will be too low. And then our CPP won't be high enough. So when we have patients with increased cranial pressure, like we said, that early sign is the LOC changes, right? But the late sign, and this means that the patient's had increased ICP for a while, is called Cushing's triad. So it is dangerous, right? It's a life-threatening occurrence that needs to be treated right away, right? So you need to be able to look at a patient's vital signs and say, oh, that doesn't look good. So if, for instance, we gave you this patient and we're telling you all about him and he came into the ER and he banged his head 2 days ago and now we give you some vital signs and we say maybe he's 184 over 73, right? So we have that wide pulse pressure. He's 42 heart rate, but you feel it and it's there, it's bounding, it's hard. It's not like a weak thready, right? So it's there, but it's still low, bradycardia. And then their respirations are kind of slow and irregular. That's a late sign of increased cranial pressure. That means that maybe they have a brain bleed, but it's been there for a couple days now. They probably have felt a little dizzy and they thought, oh, but I hit my head a couple days ago, it's normal, right? So now we're in the later signs of increased cranial pressure. What's going to happen if think back to that Monroe-Kelly doctrine. So you have all this increased cranial pressure in your head, and what happens if you don't release it? If somehow, this patient comes in and they're already in this really late sign, what are some of the things that could happen? Right, so it's going to shift, one side to the other. They're going to shift into the different compartments, or the whole thing's going to shift downward, and we're going to have brainstem herniation, right? So what happens in your brainstem? You die. Because, that's right. Because your temperature regulation, your breathing, everything's going on down here. So if it all of a sudden falls through, it's supposed to be this big, and it falls through a hole this big, and now it's being compressed. It's not able to do what it needs to do, and it's swelling at the same time. So some of the signs and symptoms of increased cranial pressure, and we already said changes in LOCs. That's the big one. That's the first one you're going to notice. Maybe all of a sudden your patient's really lethargic, or they just kind of just aren't with it. That change in vital signs is going to be a later sign. Again, that body temperature or breathing, secondary to the possible herniation, but definitely the swelling that's going on. Headache, vomiting, changes in pupil responsiveness. What's decorticate and decerebrate posturing? What's this one? Decorticate, and then this is decerebrate, right? So core. Who do we need to monitor for these? Your patient comes into the ER. Who's your top three that you're thinking in your head, like off the bat, that might have problems with intracranial pressure? Motor vehicle accidents, falls. So those would both be like TBI type things, right? Who else would have increased pressure in the brain? No, not necessarily, but it could, definitely. Stroke. How about tumors? Right? So we said that the brain, there's only room in there for the brain, the blood, and the CSF. So a tumor is material that has come out that's not supposed to be in there, right? So, even the tiniest little tumor is taking up space that normally would have one of those three things in it. I am missing a slide, but I will add it in there for you guys. You guys have it on your printouts if you printed them out or if you're in the course. But on that, I don't know how, but I missed a slide. So collaborative therapy goals are basically to identify and treat whatever underlying cause is causing the ICP. Yeah, the one that says head of bed 30 degrees, yeah. So we want to identify and treat the underlying cause and then support brain function however we need to. So why do we want the head of the bed at 30 degrees? Right, so gravity is going to kind of help, pull it down. Why don't we want it up at 90 degrees? Right, so there's two different reasons. So we don't want them at 90 degrees because then their hips would be in flexion, right? Because flexion is okay, like as long as it's not extreme flexion. So we don't want the patient sitting in bed, because we walk in all the time and they're like this. We don't want that because that's blocking off the ability to drain. Same thing with the flexion, it causes the intra-abdominal pressure to go up. But also, what do you do if a patient has super high blood pressure, and we'll talk about it tomorrow when we talk about autonomic dysreflexia. How can we make it drop? Putting them up like 90 degrees, right? If you sit them up, sometimes that'll drop the blood pressure. When we do orthostatic hypotension or orthostatic vital signs, it drops, from lying to sitting and to standing. So if we sit them up all the way, we might drop their blood pressure too low, and then we can't maintain that map needed for the CPP. Suctioning and coughing will increase ICP. So if we are suctioning a patient, usually we want to just do 2 passes, and before and after each one, we want to oxygenate with 100%. We want to put them into a quiet environment with less stimuli, because that can also increase the cranial pressure. If their belly is distended, we want to put an NG tube in, get that pressure out of the interthoracic abdomen, pressure down. If you have pressure in your brain, what else would we have you on precautions for, you think? Seizures. So tell me about seizure precautions.
Railings are padded.
Railings are padded. Okay. Are you leaving your bed up at normal height?
You're going to lower it.
Yeah, so usually we get those low boy beds that lower way down. What do we put on the floor?
Pad.
Pads, right. And that's not because, I mean, that definitely could be fall precautions too, but that's because we don't want them seizing and falling on the floor and getting hurt, right? Most of these guys are also going to be on seizure medications prophylactically. And they could be on sedation depending on how agitated they are. If they're a traumatic brain injury, so a TBI, tell me about a TBI. What happens with those patients? I know I have people who work on the neuro unit in here, or not neuro, trauma and neuro. What happens if you come in and they say, you get to go hang out with the TBI patients tonight? They're very confused, right? They're confused, sometimes irrational. They can be mean. They kind of are like a 3-year-old. Like, they're going to tell you what's going on, what's up. They're not going to be polite at all. So sometimes we need to sedate patients if they're really agitated or confused. That way they're not increasing their metabolic needs. We want to make sure that we keep their systolic blood pressure between 100 and 160 so that CPP stays above 60. What about some of the drugs that we use? Mannitol. What does mannitol do? Pulse fluid from brain tissue into the vessels. Good. What about let's see. What else can we use that kind of acts like, think of something else that would pull water from the tissue into the vein. Hypertonic solutions, right. So they work, they found in studies, pretty much just as well as mannitol, but some people just react better to one or the other. Corticosteroids, especially if it's a tumor causing it. So what is a corticosteroid going to do? Decrease the inflammation of the tumor or the abscess. So what are the side effects of corticosteroids, though? So increased risk of infections,
Increased sugar.
hyperglycemia. What else? Your bones? Eventually it would, yeah, but it could. But what does the skin look like of someone who's been on like long term? Thin. It's not mottled, but it looks mottled because it's all bruised, right? Because it increases bleeding. So it puts our patients at higher risk for GI bleeds. So with these patients, we also usually give them the H2 blockers, which is like your Zantac, your ranitidine. Did I say that right? And that's going to prevent some of that GI bleeding.
So it causes your skin to be...
No, like long-term steroids. I was just trying to get you guys to say bleeding.
Bleeding.
And then I kind of talked about the metabolic demands. We want to keep them low. So what do I mean when I say like keep your metabolic demands low? What's going to raise your metabolic demands? Fevers, stress, pain, shivering, any sort of stimulation, yeah. Oh, and we talked about the prophylactic seizure medication too. So you might see that they're on Keppra or gabapentin, usually Keppra. So your nursing management, you want to get a good subjective, find out what happened. Necessarily your patient might not be able to tell you, but whoever was there with them or bringing them in or friends or family. So you want a good history of what happened. What's GCS? Glasgow Coma Scale. What is that? Shh, I was getting there. What is it? What do we?
It determines
Your conscious
Level of consciousness, right? What's the GCS of this table? 3. So, not obviously, like, you want to be up on the higher end. What's the highest? 15. So it goes 3 to 15, and it talks about what are the 3 different things that it looks at. Eye-opening, verbal response. So it's the voice response, right? Motor.
eye-opening.
And what else? What's the third?
Eye-opening.
Eye-opening. To, like, response to stimulus, right? Did I say that right? Okay, so my medics, when do you intubate? She just gave it away, but 8, right? So less than 8 intubate is what they say. So if you come in and your GCS is 8, you're probably going to end up ventilated, but also your outcomes drastically drop. If you come in and your GCS is 13, you have a much better projected outcome than someone who comes in with an 8 or 9. Tell me about your neuro assessment. What are some of the things that you're going to do?
pupils.
You're going to look at the pupils. So what am I looking at your pupils? Size, if they're reactive to light,
Larger than the other.
if they're the same size, so equal, right? If you can track. Accommodation, what's that mean? Right, so that's when you go over and you look in your patient's eyes and you're looking to make sure that their pupils are constricting when you're flashing the light in their eyes, right? And then you kind of like put your hand up and you put the light in one eye, but you're looking at the other eye. You're looking to make sure that eye is also constricting, so consensual constriction. What other tests can you do for neuro? So we talked about the eyes, Perla constriction, tracking. Yeah, I mean, if your patient's not talking to you, you can definitely do pain stimuli. What do you guys do when you go in to do your neuro assessment on your patient in the hospital, just lying in the bed? What are some of the other things that you do? Yeah, so the palmar drift, right? So you're going to have them hold their arms out like this and close their eyes, and if there's any sort of weakness, you'll notice this arm starts going down, and they don't even necessarily know that it's happening. Yeah, so you can go back and do your cranial nerves, right? Smile, blow your cheeks, don't let me push them out, you know, blow kisses, whatever. Squeeze, you're going to have them hold their legs up, push them down. So you're going to go through your whole neuro assessment. Absolutely.
Some of my group knows, but whatever, I could care less. I'd rather, have prosthetic than being cross-eyed. But I have an artificial eye, and so I have no reaction to light. And I used to have migraines, so if you're in the brain, get a good history on your patients. Because I worked in a teaching hospital, and the resident freaked out. I came in with projectile vomiting, headache, and he does the lights. So of course I'm not offering anything. I was like, I'll show you. And he freaked and went and got the head doc. Well, a prosthetic, if you ever want to see it, just grab me, take a pen light, because it really is different than having an eye, okay, because of density. But talk about misdiagnosis if you don't know the history of your patient. I just want to share that because they're a little bit more common than you think.
Yeah.
So I just want to share that piece.
Thank you.
On assessment, I look like I'm like.
Which eye would dilate? The one that's not a prosthetic, yes. No, let's say that you have an injury on your left side and you're looking at the eyes. Which one will usually dilate? It's the ipsilateral, so the same side, right? Let's see. Nursing diagnoses. You've got all this extra fluid or edema in the brain. What do you think some of your nursing diagnoses are going to be? It could have something to do with fluid, so fluid volume excess. Do you think that you're ineffective? Dallas is over there with the book. he gets extra points for having it open, right? So risk for ineffective cerebral tissue perfusion. Good. What about goals? What are our goals with these patients? Increase the intracranial pressure? No, because it's already increased. Oh, decrease. So basically you want the intracranial pressure within normal limits. Remember, we're talking about levels of consciousness. So we want to make sure that we have a patent airway, right? Maintain the airway. What else? Talking about fluids, we want normal fluid volume. Nutrition. So you guys will hear this in pretty much every lecture you get. It's really important that we feed our patients, right? We don't want them sitting in that ICU for a week before someone says, are we giving them any nutrients?
Are you hungry?
Well, sometimes they're not lucid enough to tell you they're hungry, right? So we need to make sure that at the very, very, very longest, within 3 days, that we start replenishing nutrients in these guys. And if they can't orally take it in, then we're going to do that PPN and TPN that we talked about, right? Remember I said that these patients, every patient in the hospital, if they have some sort of illness, their metabolic needs are much higher than they would be right now just sitting at a desk. So we want to make sure that we're giving them the nutrients and vitamins and minerals that they need to do the healing. What else is going to happen if they're laying in a bed for 7 days, or even 3 days, or even a whole 24 hours? Skin breakdown. So we want to make sure that daily, at the very least, once on your shift, probably if you're in the ICU or somewhere where the patient is immobile, it's going to be much more often. But with you and me, the nurse should be assessing us once a day. But these patients, it's probably more like every hour or two, because it happens super quick, especially if they have any sort of edema or if it's moist. So we want to make sure that we're doing good skin care. What else would we do for immobility? Yeah, so if the patient can't do active range of motion, we would be doing passive range of motion, because that happens super quick too, right? We don't want them to get contracted. We don't want them to atrophy as much as they would if they would lay there doing nothing. We want to make sure that that doesn't happen. So now that we've talked about all the different pressure changes in the head, we're going to talk about a couple things that might cause it. So head injuries, any injury to the scalp, skull, or brain, and they can be diffuse or focal. So tell me about a head injury like this guy. What's he got? They bleed. Yeah, he probably just has a tiny little laceration there, right? Probably got hit with another elbow or something. It's probably not even open that much, but it bleeds like a dickens, so it always looks horrible. So when we talk about the different types of head injuries, we have lacerations, which we just saw in that guy probably. Skull fractures. So we have different types of skull fractures. Do you guys remember the different types of fractures from when you did like the long bone stuff in level 3? A lot of it's the same, right? So we have a simple fracture where there's some sort of break in the bone, but it's not displaced and it's not crumbled at all. It's not coming out. It's just a simple break. We have depressed, so that would be like, say you took a softball to the head or a baseball to the head, right? It's going to depress the bone in. We have comminuted, so maybe comminuted means what? Do you guys know? Yeah, lots of different bits and pieces. And then compound. open, right? So it's going somewhere, either out or into the brain. Like I said, when we talk about diffuse injuries, we're talking about concussion. It's kind of throughout. And then a focal injury is like a contusion or a hematoma. We also have to talk about primary versus secondary. What's a primary head injury?
The point of impact?
The point of impact. Whatever happens, the initial injury is your primary injury. So what do I mean by secondary injury?
Well, underlying.
It's caused by the primary, but not immediately, right? So it could be that swelling that happens, starts cutting off some of the blood, so you get ischemia. So basically that secondary injury is going to be some sort of ischemia, some sort of edema, or hypoxia. And when we talk about spinal shock tomorrow, we're going to talk about the same thing, the primary and secondary. Sometimes those secondary injuries don't show for a couple days. Why? I didn't hear you. Takes time, right? So the swelling doesn't necessarily, and sometimes it does, immediately happen, and it'll happen, you'll start seeing signs of ischemia immediately. But sometimes it takes a couple hours to 24 hours for that swelling to get bad enough that we're going to see the secondary injuries. So when we talk about skull fractures, this is a very specific skull fracture. It's the basilar skull fracture. So it's a fracture that happens where?
Right at the base of this.
At the base of the skull. Good. So this guy has a couple different things going on, but I'm going to show you pictures of the real stuff because there you go. So when we talk about these, what is this? Raccoon eyes or periorbital ecchymosis. What about this? Ooh, battle sign. Good. Did you guys already learn that somewhere, or did you just do your reading? Battle sign. What about this? It could be, so we're just going to call that rhinorrhea, right? Stuff coming out of the nose. Over here, otorrhea, stuff coming out of the ear. It's never a good sign when fluid starts coming out of the ear, right? So how are we going to know if the stuff coming out is spinal fluid or not? The halo sign. Where is that? Up there. So the first thing they're going to do, if there is clear fluid, is take one of the DEXA sticks and test for glucose, because CSF has glucose in it, right? So if there's any blood, why wouldn't we use the DEXA sticks? Blood has glucose. So as long as it's a clear fluid, we're going to use that. But this is what we can do if we don't have clear fluid. Has anybody seen one in the hospital done? You guys do any out in the field or anything? No? The halo sign?
Yeah, that's one the glucose stick too, where you do it on that, and then you also just do it on the capillary as well.
Oh, see, I didn't know that they could do it that way. He said that they do the dextrose on that and the capillary, and they compare the two to see if there's more there than there is in the capillary, which would indicate CSF. But for testing purposes, we're only going to do that if it's clear fluid. The halo sign, you're going to let a drop of fluid fall onto a gauze or a towel or a pillowcase. Sometimes it's already happened and you don't need to do it yourself because you can see it. What's going to happen is all the blood cells are going to kind of go to the middle and you're going to get this yellowish ring around it. So that would be a positive halo sign. So when we talk about concussion, what's retrograde amnesia? What's that? Repeated asking questions?
Tell something and then they forget it, and then they ask it again and they forget it.
Okay, so basically it's like the short term leading up to the event and the event, and maybe they can't answer those questions, definitely. Sometimes they'll have a brief loss of consciousness right after, and then they'll come to. It's not usually localized to one part of the brain. When I say coup and contra coup, what do I mean?
Like when they hit their head.
right? So I see Dylan doing this. So let's say I am in a car accident, right? And I fly forward because I don't have airbags and hit my head. And then I go back to the seat and hit back here. You don't even necessarily have to hit back there because the brain's going at such velocity. So this would be your coup and this would be your contra coup, right? So initial is coup, opposite is contra coup. And you're going to get injuries on both areas. Usually your patient starts complaining of a headache. Sometimes they can have no loss of consciousness, but it's always usually less than 5 minutes. If it's less than 5 minutes and they go to the ER, they're usually going to send them home for monitoring. If the loss of consciousness was longer, they'll probably keep them just to make sure. Post-concussive syndrome. Anybody ever witnessed it? So my husband and I both used to work psych. That's why we met. He loves telling people that we met on the St. Anthony's psych unit because I used to work upstairs and he worked in the ER. So we both worked psych. So when we moved to Vermont, we both worked psych. I moved to Massachusetts for grad school. So I was doing my nursing thing, but he started working at the state hospital right there in Worcester. Well, the unit he worked on was like the federal prison psych unit. So they were all prisoners with mental health issues. So the guy that he was with one night, he was a 2-to-1, so two staff to one patient, and there was a new charge nurse. So the one guy already got beat up by the guy and got sent home. They never replaced him, so now my husband was 1-on-1 with this 2-on-1. So they have a code gray or whatever they call it there, and restrain the guy. So they go through the whole thing. Everything's good. Guys calm down. He wasn't like a horribly unpersonable person, right? So when he wasn't misbehaving, he was nice. Probably like narcissistic behavior, you know, like can woo you and whatever. So they're done. They unrestrain him. Everybody's leaving the room. And so my husband goes to stand in the doorway because you never, you always put yourself closer to the doorway than you do, you never put the patient between you and the doorway. And he goes, "Hey, Mike." And so, my husband's like, "Yeah, can you just help me push my bed back?" Because they had restrained him on his bed. So my husband's like, "Sure." So he walks in and he's like helping him push his bed back. And he said all he remembered was somebody screaming his name. And then he doesn't remember anything else till he was in the ER. So the guy apparently punched him in the back of the head and sent him right to the floor. Head bounced a couple times. Apparently he lost consciousness very briefly, but he doesn't remember the actual event, even though he regained consciousness. So they took him to the ER, and he calls me, and he's like, "I'm in the ER. It's no big deal. Patient got me," which isn't unusual. Does anybody in here work psych? It's not unusual to get bruised and beat up, and I have crazy scars from working psych for so many years. But so, he tells me this, and I'm like, "Oh, all right." And he's like, I said, "Do you want me to come over?" Because we lived right behind the hospital, because that's where my school was in the hospital. No, it's fine. When I'm done, I'll tell you, so-and-so's coming to get me and bring me home. I said, all right. So he gets home, and he's, all lethargic and whatnot. And he says, "I'm out of work now for workman's comp or whatever. I have to go see the doctor to get cleared." Well, over the next few days, he just becomes if any of you had ever met my husband, he's very talkative. He's friends with everybody. He has never met a person that he can't sit and talk to for 8 days straight. And so all of a sudden, we had just gotten married a year before this. We had been married. We got married March 31st, 2007, and this happened April 11th, 2008. So we've been married for a year, so still newlyweds. And it comes to the point where now he has this flat affect. And I'm like, "Oh, but that'll get better. He's just depressed because he got hit in the head or whatever, and now he's out of work." So come the next month, it's not getting better. Now he has headaches. So now they have him on Lyrica and Elavil, which are horrible meds. Gabapentin, they all make you zombie-like, right? So he gets off those because he hates the way they make them feel. Every day. Now he can't drive. That's one of the stipulations from the neurologist, no driving. So every day we'd be on our way out to dinner or whatever. And the back way of our neighborhood, we went through a park, past a skate park, down a hill. every day we'd pass and he'd go, baby, look, there's a skate park right there. And I'm like, what did I just get myself into? It's been 3 months. Married this guy. This is going to be the rest of my life. And it went on like this. Like, it slowly got better. He didn't go back to work until November. And the whole time he suffered through like crazy headaches, lethargy, definite memory issues. He was born and raised in St. Pete, never left St. Pete till he was like 23. Moved up there with me for a few years, moved to Alaska for a year. But for the most part, has always lived in St. Pete. We came back. That happened in April of 2008. We moved home May of 2010 when I got out of school. And like, he'd be like, I say, oh, let's go to El Cap or wherever. He'd be like, okay, great. And we get in the car and he'd be like, where is that again? I'm like, you're the one who lived here for a bazillion years. Like, what do you mean, where is that again? So, but he still does it. He'll say, I'll say something, and now it's 10 years later, and I'll say something, and he'll be like, okay. And then like 10 minutes later, I'll say, well, don't you remember whatever? And he's like, you didn't tell me that. That's the look he gets. Because I'm over it. But, you know, I have to go with it. But, so it definitely has lingering things that happen. But his definite, like the acute stuff definitely lasted from April to November. So, and sometimes, you know, you see these football players that are taken off the field after the first concussion, or they should be taken off the field after that first concussion. And then they'll end up with like a concussion on top of a concussion on top of a concussion, and then they end up with like the post-concussive syndrome. So that's my one good story for this lecture. But there's definite, you know, headaches, lethargy, personality and behavioral changes, and short-term memory loss. Focal injuries are more in one part of the brain. So those are our contusions, our lacerations, our hematomas. That right there is a hematoma. It looks like a big wad of jelly, right? So lacerations, and this is to the actual brain tissue. So it can be actual tearing of the brain tissue. If the patient has a laceration on the brain, one of the things that we have to do is prophylactic antibiotics until we can rule out meningitis. So if that dura is torn at all, bacteria can get right in there. My sister had Chiari. Do you guys know what that is? It's like the herniation. Hers was tiny, like 7 millimeters or something. But after her first surgery, she had 4. The chair of neuro finally took over on her 4th one up at USF at Tampa General, because the other guy, just something was going on. But after the first one, she had a leak in the back of her throat. She had the CSF leak. No idea if it was there before or new, but they immediately put her on antibiotics because they didn't know if there was bacteria getting in and wanted to make sure that she didn't get meningitis, right? The contusions, that's like that coup contra coup that we talked about. So coup contra coup, you get the contusions, which are basically like bruises, right? Hemorrhages. You can get necrosis and edema in that area. We're going to talk, I'll show you the slide for coup and contra coup on the next one. Some of the things we have to look out for 7 days, let's say you have some sort of head injury, you're riding your bike, you fall off and you hit your head. And I send you home from the ER and I tell whoever's with you, just make sure over the next few days, you're going to want to make sure that he doesn't have any decreased LOC or behavioral changes. But one of the big things for 7 days that we make sure that people look out for is seizures. So seizures can occur up to a week after. There's a picture of the coup contra coup. So when we start talking about hematomas, you can see in this picture, I just thought it was a good one. It's right out of your book though. And it shows you the different areas where you can get the hematomas. So here's your dura. So this is going to be epidural, right? So outside the dura. Subdural, under the dura. subarachnoid, which means it's inside the part that separates the brain from the dura. So that's actually almost in the brain. So when we talk about the epidural hematomas, like we said, those are between the dura and the surface of the skull. They can be venous or arterial. They're usually arterial. And that's an emergency. That patient's going to be taken in. We're going to get the slides, and they're going to bring them right into the OR. They need to stop it. Why? What's going to happen if it's an artery that's bleeding? It's going to bleed really fast, right? Yeah. So we need to make sure that if it is an arterial bleed, that they're taken directly in. What are some signs and symptoms of an epidural hematoma? Anybody know?
Isn't it like quick? Like they lose consciousness quick?
They lose consciousness quick, so they go unconscious, and then they come back for a brief amount of time, and then they lose it again. So it's unconscious, come back, gone. That's the classic. What's the surgery that they do where they have to go in and remove that stuff? How do they do that? How do they do the evacuation, though? Craniotomy? What does that mean? Well, it's not always the cap, so wherever. But yeah, they have to remove a part of a bone to get down to evacuate that hematoma, right? What? Suck it all out. Sometimes if it's an emergency, they'll do burr holes even, and they'll go in and do the evacuation that way. It's pretty wild. The floor that we're on is a trauma floor, so a lot of patients have craniotomies, and a lot of them, they haven't put the bone back in yet, so it's very indented, and it looks really weird, and they have to wear helmets.
That's the blood is bad to the tissue of the brain, right?
Because what?
The blood is also bad for the tissue of the brain.
Well, we need to get it out of there just because of the pressure, but what do you mean?
Like, isn't like the blood kind of acidic against the, maybe that's not the right word.
No, if it's a small enough bleed, sometimes they'll just reabsorb themselves.
Okay.
Yeah, so, I mean, it doesn't do brain damage necessarily, like the blood itself. Subdural, so that's between the dura mater and the arachnoid covering. These are usually venous. So obviously they're not pumping out the blood like an artery would, so they're slower to develop. And we have acute, subacute, and chronic. So what does acute mean?
Right now.
Right now. So usually the bleed, shows up within 48 hours. They'll start showing some decreased LOC, start complaining of a headache. Subacute, meaning it can take 2 days to 2 weeks. Remember, they're slow bleeds, so it could take up to 2 weeks before the patient starts complaining about headaches. Sometimes when you, I don't know if anybody read, the book was saying, sometimes when you do scans of these bleeds, the subacute ones, they'll actually look like they're getting bigger on the scans, but it's not. It's just the blood products breaking down. And then chronic. So usually when we talk about chronic bleeds, who do you think would be a chronic bleed? Alcoholic. Why?
Blood's thin.
Blood's thin, so somebody on blood thinners maybe. What else happens in the alcoholic brain? Atrophy. Same thing with the elderly. So your elderly and your alcoholics and people on blood thinners are like your people who you really have to worry about your chronic bleeds. They're misdiagnosed a lot at first, and it's because they kind of just resemble, they hit their head, it might have been 3 weeks ago, and now maybe they're a little confused or complaining of blurriness or something. So what do we always, when an older person starts complaining, they get a little loopy and they start complaining of blurriness and maybe some dizziness, what's the first thing we usually think of?
UTI.
Like a TIA, right? Did you say ATI? Oh, UTI. Could be a UTI too. So, we go in, we don't ever think, oh, it's because they hit their head 3 weeks ago, or maybe we don't even get that in their history. I got a call the other night, and she was like, he fell on Thursday, Saturday I was there, he was fine. I got there today and he's all confused, crawling out of bed, pulling the covers off. But I don't think it was from the fall. And I was like, it could be from the fall. So of course my first question was, is he a DNR? Because that's always my first question. Is he a DNR? Did you tell the family? Could you explain what a slow bleed is and see if they want to send him into the ER? Because anytime you have an elderly person or an alcoholic or someone on blood thinners that has fallen anytime in the last couple weeks, you really have to think that maybe it's a bleed that's just been slowly building since then. So think of the elderly and the alcoholics again. What do they tend to do? Fall. So it could be that maybe they had a little bleed, but then they fell, and now they have a little more happening, and then they fall again, right? So getting a good history on your patient is absolutely necessary. As far as prognosis with these patients, it depends on the clinical presentation, so what's going on with your patient, and where it is in the brain. Also, how healthy your patient is, how quickly it was caught. Diagnostic studies for a brain bleed, CT is usually the one that we do. They can do an MRI. They almost always will do a cervical spine x-ray if you've had any sort of head injury, because usually if you think about it, like you fall, you hit your head, your cervical spine is, no matter which way you hit your head, it's involved in some way or another. So they need to make sure that there's nothing cervical going on, as well as the head CT that they do. And then obviously your Glasgow Coma Scale. So your nursing management goals, so your goals for this patient are that they are going to get their ICP back where it needs to be, and that should say 5 to 15, not 0 to 15. Maintain adequate cerebral perfusion, so we want to make sure that they're getting the blood to the brain. Remain normothermic, because remember, if there's any swelling going on and it's at that brain stem, it could be that they're unable to regulate their temperature on their own. What's that called? Poikilothermia? You guys had that in level 3, right? You guys talked about it a little bit. We'll talk about it tomorrow too when we talk about spinal cord, but yeah. We want to make sure that they're free from pain, discomfort, and infection, especially the pain and discomfort, because that's going to raise their ICP. And that their cognitive, motor, and sensory function is back to baseline or as close as we can get it. Your nursing interventions, you're going to monitor, obviously, your ABCs, your LOC, any neurological deficits that your patient has. The other thing they can do, and they did it to my sister when she had hers, because she just kept producing excess CSF, is they actually put a shunt in. And they can do internal shunts that people who have, it drains into the peritoneal, right? So it's internal, you don't even see it, you don't know they have it. They go every few months to get it checked to make sure it's not clogged and everything's still working the way it's supposed to be working. Hers, because it was temporary, and they talked about eventually if it didn't clear up, they would have to do the permanent, but hers was temporary, so she was flat on the bed. They didn't want her head of the bed up to 30 degrees. Her doctor wanted her absolutely flat while this whole thing was going on. And, everything's doctor preference. And then every hour they would come in and they would take off 10 cc's of CSF, which I was like, well, won't she just keep producing to compensate for the loss? But, I'm no neurosurgeon, so... And eventually it did clear up and she was fine. So they can do that. So if you're the nurse, you might have to monitor that CSF drainage. Remember that you're going to try and prevent coughs. If they have some sort of tickle or dry cough, you're going to obviously ask for some sort of cough suppressant. Suctioning, like I said, we're going to do only 2 passes with breaks in between, 100% oxygen before and after. If they're vomiting or nauseous and you think they might start vomiting, call the doctor, get some Zofran or something. What are some of the other things that we mentioned? What about the head of the bed? 30 degrees. What about your hip and neck?
Not flex. Not complete.
Right, no extreme flexion, right? We talked about the prevention of hyperthermia. We talked about a couple issues with immobility. So we talked about the skin, right? what else can happen if you're laying in bed? And we talked about the muscle atrophy. What else is going to happen if you're not up moving around and maybe not drinking enough water or getting enough fluids?
DVT.
You can definitely get DVTs. We want to do some sort of DVT prophylaxis as long as they're not bleeding, right? Okay. And then, what else? Constipation. Yeah. So when you send these patients home, you want to make sure that you do some teaching with them, especially if it's one of these patients, like I said, that came into the ER and maybe the loss of consciousness was only a couple of minutes or less than a couple of minutes. And so they send them home. So one of the things that you're going to do is lots of patient education along with whoever's going to be with them, because they're never going to go home on their own. They would end up keeping them. So if they have any increased drowsiness, nausea, vomiting, headaches, stiff neck, seizures, any visual changes, behavioral changes, sensory disturbances, no driving until you're cleared by the doctor. And then we want to make sure that we get a good idea of what medications that they're on that can cause fluctuations in the pressure, and also if they're bleeding, to make sure they're not in anything that's going to continue the bleeding, right? So stop any of their anticoagulants. All right, so we're going to talk about brain tumors. So this can also obviously increase your cranial pressure. When we talk about a primary brain tumor, it means that it started in the brain. It wasn't breast or lung cancer that went to the brain. It was actually a brain tumor that started in the brain. When we talk about secondary, that's your metastatic tumor. And usually the brain is usually a lung or breast that went to the brain. All of them are deadly if not treated because it takes up more space, so it's going to increase that cranial pressure, right? So it's going to lead to brain herniation. More than half of them, most of them are malignant. And then the ones that are the primary in the brain, they rarely metastasize. So this is a picture of a couple different types of tumors. So we have different types, and they're named by the type of brain tissue that they take over. So your glioblastoma is that first picture, and that's kind of like right in the middle of the brain. It's the ones that are usually inoperable. They might do some palliative stuff on them. They could go in if they really think that they've got it down and do some surgical interventions to try and get it out if it's small enough and not around any specific arteries or anything. But usually those are the ones that when you hear somebody has a glioblastoma, you just kind of shake your head because they probably don't have very long to live. They're quick. And then the meningiomas are the ones in the other two pictures. Those are both the same brain if you read the little thing in your book. They're just different cuts of the brain to show you how, at the top of the brain, it just looked like it was off to the side, but when they cut through the brain, it's actually pushed an entire, that whole ventricle is pushed over, almost closed off, and the second one's almost closed off as well. Clinical manifestations are just going to depend on where it is in the brain. Complications. What do you think a complication of having a brain tumor would be? And especially if it's that big, right? So that's a huge portion of your brain that's taken over by a tumor. Yeah, you're going to have all those same ones as the increased ICP. You're probably going to have seizures.
Behavioral changes.
Definitely behavioral changes. With brain tumors, your patient will complain of headaches. They're worst at night. They wake them up. They're kind of just like there. They're not like sharp and stabbing or anything. They're just a dull, constant throbbing. Usually they get vomiting that doesn't have any nausea that comes before it. They just have the vomiting that comes out of nowhere. And then the increased ICP. So when somebody comes to a doctor and they have a brain tumor, or they have some sort of, all of a sudden, like adult onset migraines. I've never had a migraine before, but man, the last 2 months I have had these headaches that won't go away. The orthopedic surgeon that I worked for before I came back to full-time teaching, died of a glioblastoma. Like they found it in July, they did surgery, they thought they got it all, they thought he was getting better, and then he was dead in December. But the way they found it was he started having headaches. So, so the treatment goals are to figure out what kind of tumor it is and where it is. Try to either remove or decrease the tumor mass. What are some of the ways that they can do that, you think? Radiation, chemo. Sometimes they'll put seeds in. They'll put seeds directly into the brain, kind of like they do with the prostate and stuff. Sometimes they have these chemo wafers that they'll put in. So studies, the MRI is going to be your best bet if you're looking for a brain tumor. They will do CTs, PETs. Collaborative care, again, they can do surgical therapy. Sometimes they know that they're going in and they're not going to be able to remove the whole thing, but they remove enough palliatively so that that patient maybe doesn't have the signs and symptoms that they have now. Same thing with the radiation and the chemo and the medications. Sometimes we know, you're going through all this and you're taking all these drugs and doing what you can, and sometimes it's just to prolong your life for a few months or get rid of some of your symptoms that you're having. Radiosurgery is where they go in and it's a very small space and it's done with basically like, the ones that go in and they do the bladder surgeries now with the robots, kind of like that. So again, the behavioral and personality changes, they could just be super labile. 1 minute they're talking to you and you're their best friend. The next minute they think you've just stolen something or that you're having an affair with their wife, or, it very quickly changes with these guys. And you can have a great day with a patient and come in the next day and it could be the worst day with the patient. It's really hard because you have to remember that patient's not doing that just to be ornery, right? They don't really have any control over it. So you have to be able to, in your mind, say, yes, he's kicked me 6 times, he's spit on me, he's fought me up and down trying to get him on the toilet, he tried peeing on me, but, you have to not want to retaliate towards that patient. Confusion and disorientation, memory loss. Do you guys think that if you had a brain tumor you just got diagnosed with and you ended up in the hospital and you were doing things, compulsive little behaviors that you had no control over, but in your mind you knew that you shouldn't be doing them, but it just keeps happening and maybe you keep losing your temper and you feel really bad, do you think that could lead to some depression? Yeah. Safety issues. If they have all those behaviors we just talked about, you might have to have the padded rails, you might have to have a sitter. I know on the trauma floor, we get a lot of the traumatic brain injuries at Bayfront. They have the chairs, they'll pull them up next to the desk if they're really having issues and sit them at the desk. Otherwise, they all have them on the video monitoring. Someone sits and watches a monitor on, 8 or 12 rooms. They have the cameras in. They could need a lot of help with ADLs, which could really irritate them, make them a little more depressed and anxious. Language deficits, like they know that word they're looking for and they just can't find it. I had a patient the other day, I went to go see him, and usually I only get 1 or 2 words out of him, but he was doing pretty well the other day. And so I got out of him that somebody sent him a card and that he wasn't sure what to do with it, but then he kept going like shirt or something, and I felt super guilty because I couldn't really understand what he was trying to get to, so I was like, can you go get it for me? So then he couldn't find it. But I imagine like how frustrating that must be, that in your head you know what you want to say and you just can't get it out, right? Yeah. So that leads back to maybe some of the behavioral problems. They just get irritated. Any questions? No questions about any of the head or
You say the primary tumors are less likely to
metastasize? Yeah.
Those tumors, can they